Welcome to this explainer. You know, when a patient receives a new kidney, the stakes are absolutely incredibly high. Figuring out exactly what's happening inside that allograft can literally mean the difference between saving the organ and losing it. So today, we're going to put on our detective hats. We're going to learn how to read the vital clues left behind by radio tracers to unmask exactly what is going on in there.
Okay, let's dive into this playbook. Here is how we're going to break it down today. First, anatomy and the protocol. Second, establishing the normal baseline. Third, differentiating the great imitators. Fourth, catastrophes and fluid collections. And finally, we'll wrap up with the master diagnostic matrix. All right, section 1, anatomy and the protocol. Because before we can find the culprit, we really need to understand the crime scene. Notice how the allograft isn't actually placed in the usual anatomical position. You essentially get a pelvic kidney tucked right down into the right iliac fossa. For technical reasons, the artery is anastomosed end to end, the vein is attached side to side, and the ureter is implanted directly into the recipient's bladder. But, surgical success is really only half the battle here. To keep this kidney alive, we have to actively fight the body's natural immune response. The pharmacology involved is totally non-negotiable. Immunosuppressive therapy, particularly using calcineurin inhibitors like tacrolimus or cyclosporin, is strictly required to prevent rejection. So how exactly do we monitor this carefully placed, heavily medicated kidney? Well, we use the TC99M MAG3 dynamic renography protocol. It helps to think of this as a three-part chronological mental checklist. Step 1 is the vascular phase, where we measure perfusion. We're looking at the arterial flow both visually and quantitatively. Then we move to step 2, the uptake phase, where we assess the actual tubular function and cortical extraction. And finally, step 3 is the drainage or excretion phase. This is where we literally watch the radiotracer clear out of the kidney and migrate down into the bladder. Following these 3 steps, in this exact order, is how we catch the abnormalities. Let's move on and see how this builds. Section 2, establishing the normal baseline, or what I like to call the perfect curve. Now, what's really interesting about this is this beautiful, steep upward curve. This right here is the visual signature of a perfectly functioning transplant. We see prompt perfusion that perfectly matches the adjacent iliac vessel, and that leads to peak activity happening right around the 4-minute mark. But just as important as how fast it goes up is how fast it comes down. That prompt, near-complete washout by 12 minutes shows the activity progressively and safely migrating into the bladder. When you see this curve, you can breathe a sigh of relief. You're looking at a happy, healthy allograft. Which brings us to section 3, differentiating the great imitators, ATN versus rejection. So, here is where the real drama of our explainer begins. In the early post-op window, patients can experience either acute tubular necrosis, known as ATN, or acute rejection. Now, clinically, they present identically, but they are driven by entirely different underlying pathologies, and they require vastly different treatments. So the crucial point is figuring out which is which. And the secret lies in time. On a baseline scan in those first 1 to 4 days, acute rejection might actually look totally normal, whereas ATN will immediately look abnormal. But if we track their evolution on serial scans, their true identities are revealed. Acute rejection gets progressively worse, while ATN, if you just give it a little time, naturally improves. Let's zoom in on that ATN signature for a second, specifically that progressive cortical retention. The curve goes up, sure, but it just doesn't come down. Why is that? Well, because ATN is a tubulopathic issue. The plumbing is literally backed up at the microscopic level. The scintigraphic signature shows preserved or maybe only mildly reduced perfusion, meaning blood is flowing into the kidney just fine, but that's juxtaposed against profoundly diminished function. Clinically, the patient is producing almost no urine, despite having plenty of blood flow to the allograft. This usually develops in minutes to hours, mostly in cadaveric transplants, and typically resolves over a few weeks. It just needs time to heal. Now contrast that with acute rejection, where we see this rapid deterioration over just a matter of days. Unlike ATN, this is a vasculopathic problem. It's an obliterative, small vessel disease triggered by T-cell and humoral antibody immune pathways. The small vessels are literally being choked off. Because of this, perfusion deteriorates much faster and way more severely than function in the early stages. The curve shows GFR and ERPF falling sharply, resulting in poor tracer uptake and delayed clearance. If we don't catch this, and catch it fast, that allograft is in serious trouble. And it's not just early on that we have these deceptive mimics. Months or even years later, we face another pair of lookalikes, chronic rejection versus cyclosporin toxicity.
Chronic allograft nephropathy, or chronic rejection, is humoral. It's irreversible. It's an inevitable progression that shows decreased tracer accumulation and a really slow washout. But cyclosporin toxicity, that's a pharmacological mimic. In its late phase, it structurally mimics the exact failure pattern of chronic rejection. But here is the absolutely essential difference you must remember. Cyclosporin toxicity is entirely reversible with drug withdrawal. Identifying this correctly literally saves the kidney. Let's pick up the pace a bit because things are about to get urgent. Section 4, Catastrophes and Fluid Collections. The extremes. Look at this. This is what we call the photopenic void, and frankly, it is terrifying. It signifies a complete and total absence of perfusion and function. The radiotracers simply cannot get in. When you see this massive dark void, you are looking at a terminal event for the graft. We're talking catastrophic scenarios like hyperacute rejection, which happens in minutes to hours due to preformed antibodies, or renal artery or vein thrombosis. And remember a crucial anatomical note here. Because a newly transplanted kidney entirely lacks native venous collaterals, a vein thrombosis is just as devastating and terminal as an arterial thrombosis. But hold on. What if that dark space isn't the kidney itself, but a pocket of fluid sitting next to it? To figure out what kind of fluid we're dealing with, we have to ask a deductive question during delayed imaging. Does the radiotracer progressively accumulate in a photopenic defect outside the urinary tract over a 2-hour period? If the answer is yes, if that space gets brighter and brighter with tracer over those 2 hours, we found our culprit. It is a urinary leak or a urinoma. Active tracer is literally leaking out of the plumbing and pooling in the patient's abdomen or pelvis. This usually happens days to weeks post-op and it requires immediate intervention. But let's follow the other branch of our diagnostic decision tree. What if the answer to that first question was no? What if the fluid remains totally static? Then we have to ask, does the activity in that defect simply equal the background activity without accumulating? If the activity equals the background and just stays static, it's a lymphocele. These usually pop up a bit later, around 2 to 4 months post-op, and it's due to a lack of lymphatic drainage around the surgical site. It's not leaking active urine, it's just a static pool of lymph fluid. And hey, if it stays a complete dark void with absolutely no activity at all, then you're likely looking at hematoma or an abscess in those first few days. See how perfectly logical this whole diagnostic process is? Which brings us to our final section, Section 5, the Master Diagnostic Matrix. This is where we synthesize all these patterns. And this brilliantly illustrates how all the isolated pieces fit perfectly together. Variables like perfusion and serial evolution lock in the final diagnosis. Think about it. If you see preserved perfusion but diminished function that actually improves on serial scans, you have ATN. If you have poor perfusion that gets dramatically worse over days, you're dealing with acute rejection. If perfusion is totally absent from minute 1, it's a terminal thrombosis or a hyperacute rejection. And if you have poor tubular function months down the line that is completely reversible, you've caught cyclosporin toxicity. This matrix right here is your ultimate playbook for unmasking these pathologies. So we've seen how incredible the human eye and logical deduction can be at reading these complex signatures. But it leaves us with a pretty provocative thought. Since these patterns rely so heavily on precise curves, subtle perfusion differences, and complex matrices, how will the future of artificial intelligence and machine learning evolve our ability to instantly decode these scintigraphic patterns? I mean, couldn't AI spot the difference between ATN and rejection hours or even days before the human eye could? It's a fascinating frontier for medical imaging. Thank you so much for joining me on this explainer, and as always, keep questioning the data